So guess what? We're back, right? Because we are making sure that every video that you get from Dr. Shelly on HETV, part of YouTube, every video that you get is teaching you how to pass the Ngn Nclex. So the videos that I made before the Nclex changed are very different from the videos I'm making now. So you get to reap the benefits of hot off the press videos that will help you pass for the Ngn next generation Nclex exam. That's important because you probably know at this point, I mean, unless you were under a rock and sleep and maybe even in a coma with the Glasgow scale of 3, you probably know at this point that this Nclex exam has like a minimum, not to say you can't get a whole lot more, but it has a minimum of 3 unfolding case studies. Unfolding case studies just means they build on each other. You get 6 questions each. The first question always has to do with recognized cues. We did that video before. You better catch it before you do this one. That same video that we did, we included analyzed cues. So that's the clinical judgment model, right? Remember that the clinical judgment model is 6 parts. Recognized cues, which is clues, but recognized cues is part 1. Analyzed cues is part 2. Then we gave you a video on prioritizing your hypothesis. And we said when we're looking at the clinical judgment model of number 3, prioritizing your hypothesis, you have to be very careful because that's where the test is trying to see if you will confuse this diagnosis with something similar to it. So maybe they'll take like Crohn's and see if you're confused with ulcerative colitis. Maybe they'll take Crohn's and see if you're confused with diverticulitis. Who knows? But they're going to compare it to another disease. The most common of which for any test in America would be to compare Crohn's and ulcerative colitis and give you a select all on one while throwing other kind of garbage from the other in the select all. I'm just saying. So that was number 3, the 3rd part of clinical judgment. Right now, we're going to do one of the hardest ones yet. This is where we generate solutions. This is part 4 of the clinical judgment model that's on the Ngn Nclex exam. So what that means is that we're going to still take Crohn's because that's what we're teaching. We're taking Crohn's and showing you how this applies with clinical judgment and the 6 parts of the clinical judgment. This is part 4. Now, I did mention that this is one of the hardest ones. And why is that? Well, if you watch my videos from before, because you know you just go to the playlist, you'll see a ton of videos. There's like damn near 400 videos. But if you ever watched one of my more common, popular videos, I talk about the fact that when you take this test and you're looking at the different ways you could fail it, the number 1 area of failure is basic care and comfort. So if we think about, well, where would that fit into the clinical judgment model? So if you looked at your candidate report, you know, the paper that tells you you failed your NCLEX, and you look on there and you see, oh, I did a below or near, because that's bad too, but I did a below or a near in basic care and comfort. Well, that's a lot of what we're about to do. Generating solutions is the nurse's plan of care, the basic care and comfort. It has a lot to do with teaching, diets, comfort measures, sometimes non-pharmacological treatments, over-the-counter types of things if you needed that, position changes, mouth care or whatever. It's all the stuff that makes you a nurse and not a doctor or a pharmacist. Basic care and comfort. And what I encourage you to do, just a side note, because I'm always trying to help you pass, right? You know, it doesn't matter if you failed 20 times or graduated 30 years ago. I told you before, if you're ever going to come back and try it, it's with this test, because people have been passing this test right and left, like boom, pass. After failing 10 times, boom, pass. After being an internationally trained nurse that tested 8 times, boom, pass. After failing this test and graduating 16 years ago, whatever it is. All of those, by the way, are not just like I made them up. Oh, no, honey. all of those I just described for you are in my inspiring testimonies, because that's what we do. We make you a nurse. Okay, so this is your test to pass. So if you know that you failed in basic care and comfort, which is the #1 area of failure on NCLEX, this is your guy right here. This is the case study version of basic care and comfort. So let's get started, shall we? Okay, so when you're the nurse and you get that admission with Crohn's or ulcerative colitis, and by the way, what I'm about to say on these patients goes for both of them for the most part. The good news is you don't have to separate that. That was only in prioritizing your hypothesis. So what I'm about to say, you can apply to both. So this video won't be that long, but it's one of the most important in the series, okay? So let's get started. Here you go. Generate solutions means you just got this admission in. They're feeling like shit. They're in lots of pain. You already know we went over the signs and symptoms. They're cramping. They're sick. They're having diarrhea, maybe even some bloody stools. They're scared that they're having more complications. They keep going in and out of the hospital. Whatever they're trying to do diet-wise may or may not be working. I mean, they're sick, right? They're really, really sick. Remember, we don't admit people to the hospital unless they're really, really sick. So they probably have some electrolyte imbalances, some dehydration, some hypokalemia. What the fuck is that? Decreased potassium, right? You know that already. You know that if you're going to be having diarrhea, your K sucks. Like your K is super low. Yeah. Okay. All right. Okay. Here we go. Now, what are you going to do? What are you doing with this person that's coming in super duper sick or they wouldn't be in the hospital? Well, automatically we're going to make sure that we get an IV in them and make them NPO, right? And depending on how unstable they are, well, you know that IV is the first nursing action because that's going to get them some fluids and maybe their blood pressure's low because they lost a lot. So you got to stay with your girl here. You have to critically think, what is my highest priority with this patient that just got admitted with this diagnosis? And depending on what their vital signs show, because you and I both know low blood pressure is what you see with dehydration or fluid imbalance. And that low blood pressure can make your kidneys stop working, right? Because we say no BP, no PP. What does that mean? No blood pressure, you keep hanging on and walking around here with no, well, maybe not walking, but you keep hanging on around my hospital with no blood pressure. Soon you're going to have no kidney function because you can't make urine and you can't do anything the kidneys is supposed to do unless you have literally a really good blood pressure. Okay, so kind of think about that. If the blood pressure is low and the patient's tachycardic and they're looking like shit and all this, of course you're going to start that IV first. That's just common sense because you want to hang some fluids because what controls the blood pressure? Fluids. Fluids make the blood pressure go high. Lack of fluids or dehydration make the blood pressure go down. You get it. Now, we did make them NPO, and they're going to be NPO until we get on top of this. That's called bowel rest, right? It's fancy $4 way of saying it. But you are not eating anything right now. Now, eventually, we'll switch it to clear liquids, full liquids, you know, soft, blah, blah, blah. But right now, on admission, in my hospital, in this room, your ass ain't eating nothing. Not yet, honey. Okay, they might be mad at you, but whatever. So you got your IV fluids, you've drawn some labs at the same time you start the IV. You know you're going to be monitoring for those labs to come back. We already talked about what those labs were. Okay, so you have to go to the other video for that. You're going to do an abdominal assessment. And I don't know if you remember an abdominal assessment, but very often this might show up on somebody's test. I know when I was in school, it showed up on my test. And a lot of my students that I tutor for nursing school, it shows up on their test. So who knows? It might show up on an NCLEX, right? So you better know how to do an abdominal assessment. So here's what you got to know, because I'm going to go in order like a drag and drop type of deal. A drag and a drop makes you the prop. Oh, that didn't even make sense, but whatever. Okay, so here we go. You ready? Part 1. Have the patient empty their bladder. Don't nobody want you pushing on their stomach and they got a full bladder. Have her empty her bladder. Part 2, when she come back to the bed, lay her flat if she can tolerate it. Reasonable. Then the next part is easy. You're gonna do like a head to toe order of stuff that you do for an abdominal assessment. What do I mean? Okay, watch this. Visualize the abdomen, right? What happens when you visualize the abdomen? Well, you can see distension. If I was talking about a cirrhosis patient, you can see collateral veins. If I'm talking about a patient and you don't know why they're here, but they do have abdominal pain and you don't know what it's from, and maybe they are complaining of a right lower quadrant pain, you could see a scar in the right lower quadrant. You could ask, did they have their appendix removed? If and when they say yes, you're good. You know it's not the appendix, because that right lower quadrant pain is something else, because they already had their appendix removed because you visualized the scar in the right lower quadrant. Stay with me, right? Okay. You could see a pulsating mass around the umbilicus area. What's that? An aneurysm. And you, my dear, 20% of aortic aneurysms are picked up by the nurse who did their assessment. So you already know what I'm talking about, okay? See? Okay, so then keep it moving, right? We said a head to toe. Well, that was first. What's a little lower than that? My ears. Y'all like my earrings? I tried these out for the first time ever, but yeah, these my earrings, squirrel. But yes, ears. Now, what do ears mean? Ears is auscultate the bowel sounds. Common sense. Put the stethoscope to the belly and do you, boo. But before you fix your lips to say absent bowel sounds, you better have listened for 20 straight minutes. 20 minutes, Shelly? Really? Putting your head down on somebody's belly with the stethoscope in your ear for 20 minutes? Are you serious? Yes, I'm fucking serious. Because absent bowel sounds means bowel obstruction, and that's a whole nother category of cray-cray. And so before you fix your lips to say absent, you better hope and pray that that absent was correct, and you don't cause this patient to get a workup for a bowel obstruction, including surgery, and you was wrong. Okay? So 20 minutes, 5 minutes in each quadrant before you can say absent bowel sounds. Now, let's talk about that auscultation, shall we? Because I find that my students just don't know what they're supposed to hear. If the patient's normal, if the patient's totally normal, you will hear bowel sounds easily before you even do much. And I will give you a nice little tip. The right lower quadrant is where you almost always hear bowel sounds. That's the last place they would disappear. So bowel sounds are, if they're in the right lower quadrant and they sound just as normal as a day is long, you're good. You feel me? Now, what if they're hypoactive and you got to take forever to hear them? That's a tip, because before they become a bowel obstruction, sometimes they're just hypoactive, or constipation, they're hypoactive, right? Okay, so what if they're hyperactive? That is typical for diarrhea. So when you're listening for bowel sounds, hyperactive is diarrhea, hypoactive is constipation. What if you got both? How can you have both? Oh, you can. You can have, watch this, hyperactive here and hypoactive here. So what would that mean? Because I told you, you always hear them in the right lower quadrant. Remember that little tip? So what if they're hyper here and hypo there? Well, we're starting an early bowel obstruction or paralytic ileus, because the hyperactive bowel sounds are above the obstruction and absent or hypo is below. I hope that makes sense, okay? Now, that was auscultation, right? Bowel sounds, right? You're good. What is the next step? Because we said 1 was visualization. 2 was my cute hearing, auscultation. Number 3 is a combination of hearing and tapping. What is this? Percussion, right? If you percuss the belly, what should it percuss? It should percuss as tympani. So in your case study, if they say the doctor's assessment picked up dull dullness on percussion, that's not what I told you were supposed to hear. You were supposed to be hearing timpani. So ears and hands together, going down the body, head to toe, eyes, ears, hands. This would be ears and hands together, would be percussion, and you should be percussing timpani, okay? All right. What would dullness mean? Well, dullness would mean you're either hemorrhaging, or you have ascites, or you have a tumor in your body in the area where you were percussing, because what gives you dullness? Solid and fluid-filled structures, okay? All right, let's move on. Now, the last step of a abdominal assessment, what you're doing on this patient, is palpation, right? And you're not doing a whole lot of nothing to this patient because you already know they in pain. Don't act stupid now. Don't be pushing and shoving. You can gently palpate the patient's abdomen to find out where is this pain, can't you? Because what did we say? If it's going to be Crohn's, it's right lower quadrant. But if it's ulcerative colitis, it's left lower quadrant. So those are like some pertinent like issues, right? You got to kind of know, well, where are they feeling their pain the most? It may just be generalized. Who knows? They could have a hot belly. And let me just say that. What if this patient has a hot belly? What is that called? Peritonitis. What if the patient's ulcers with ulcerative colitis have perforated, bled, and ruptured, and you got a GI bleed? What if? How would that change the abdominal assessment? Well, first of all, those patients would have a board-like rigid abdomen. Oh, you don't want that. Because if you look in your Oh My God packet that you should have got for free by now, and if you didn't, now you got to pay for it. If you look in that Oh My God packet, board-like rigid abdomen is bleeding out or perforation. That's bad. That's a medical emergency on page 7, isn't it? Board-like rigid abdomen. I'm gonna say that over and over again. Board-like rigid abdomen. Board-like rigid abdomen. Board-like rigid abdomen. Okay, because I need you to know it. Okay, so board-like rigid abdomen is a medical emergency. The patient's hemorrhaging. That's what caused the hardness, the blood pouring into the area. Okay, so that's ugly. During palpation, your patient may have rebound tenderness and pain at McBurney's point. Who would that be? Appendicitis. So I'm just giving you the holy hookup. That was for free. That was extra. But I mean, we are in a GI lecture, so I had to, treat you. So here we go. Abdominal assessment. What else are we doing? We're anticipating, right? Anticipating the patient might need antibiotic, steroids, and electrolyte replacement. Just being smart. How are we knowing if we need any of these? Oh, we're going to be watching the white blood count. We're going to be watching the electrolytes for your BMP and CMP, complete blood count, BMP, CMP. We're going to be also seeing what the sugar is on the BMP or CMP, because we know that steroids can increase your blood sugar. Okay, so we're just watching stuff, right? We already did the vitals. That was, up at the top somewhere. But that's like common sense. I ain't finna waste no time on the vitals. I already told you low blood pressure, tachycardia. That's going to be some dehydration, hypovolemic shock type shit. But other than that, you already know. Antidiarrheals. These are important. And look what I did, because they're hard to understand. People don't know what these words are. You get these on a test and you're looking cross-eyed and retarded. So let's just look at it together. Diphenoxylate atropine sulfate. What the hell is that? That is Lamodal. And it's a controlled substance, so you normally have to count this when you take it out the Pyxis. Just saying. Loperamide, another antidiarrheal, is Imodium. These antidiarrheals are great for these patients, but they're contraindicated in anybody else with diarrhea. Let me say that again. Antidiarrheals are very appropriate for these patients, Crohn's and ulcerative colitis. They are not allowed with patients that have diarrhea for any other reason. Because the last thing I need you to do with your little diarrhea having self is to stop the diarrhea and not get the bug out of your body. Does that make sense? I hope it does. Okay, moving on. You got to do daily weights. We done talked about weight loss with everybody. They need to have daily weights. And let me just tell you, a way to know your patient is improving is they gained weight. Huge, okay? Strict I's and O's, of course, like for real. Okay, check their stool pattern. You're looking at every stool. You're checking for blood, consistency. Is it improving? Is it getting worse? check the stool pattern. Skin integrity. Oh, make no bones about it. If you got diarrhea like these people have diarrhea, they have excoriated bottoms. They may have drainage from fissures or fistulas. They may be pooping through the vagina. Any number of things could be going on, and they're all really bad things. So you've got to be on your shit and make sure you check down there to see how they're doing. And I'll tell you this, look, your doctor or nurse practitioner may order topicals to make that excoriated bottom better, right? Okay, or just other treatments. Let's look at some common things. We have zinc oxide. We have A&D ointment or vitamin A&D ointment. We have antifungal topical cream, very common. Let me say that again. Antifungal topical cream usually ends in azoles, A-Z-O-L-E. This is very common. Tux or witch hazel pads for basic care and comfort might make them feel better. And don't you dare forget sitz baths. Oh, hold on, honey, in case you crazy. I'm coming. Don't worry, you Jerry curl shit. Sometimes I got props and sometimes I don't. Here is the sitz bath. I'm gonna bring it up closer. It has a bag in it. You hang that bad boy off the shower stall like this. You put this part in the toilet with the top up and then put the top down over it. And then you sit your behind down, and this is hot. The water in the bowl is warm. As it cools off, you add more hot. Sorry. Hope that makes sense, okay? Boom. Sitz baths. You kind of got to know about that. Oh, and you're going to kick my butt because I forgot to tell you which packet we're in. We're always in the Oh My God packet, and we're always going to pick the topic of the day. So you see it's gastrointestinal. You open it up, and you don't have much room left after your other videos. So I use this anti-diarrheal page for the notes we're doing now, and I just squeeze the little stuff in there, whatever I'm gonna do, basic care and comfort, whatever. You could put it on the Crohn's page or whatever, but just don't do notebook paper. Keep everything in the packet. Find some page that the shit can go on, okay? For real, you'll see why later. Okay, so anyway, these are your anti-diarrheals, so it goes on the anti-diarrheal page, right? And these are probably there anyway, so it's perfect. Really read the page, okay? Let me do this with you right quick because some of y'all be acting crazy. Peep this. What do you see? You see loperamide and you see diphenoxylate. What the fuck you call that? Hydrochloride, atropine sulfate. Okay, so all of that was what I wrote on the board. That's why the handouts matter. Because if it's on a handout, it might show up on a test. Hello. Okay. Just trying to tell you why you should care about these handouts. Okay. All right. So you got it. You got your little anti-diarrheals. You got your daily weights, strict eyes and nose, check the stool pattern, skin integrity. Then we talked about the different things to use. We just did the sitz bath. I showed you a prop. I think I should get points for that. And then you already know this because if you ever had a baby, they told you this. Keep the bottom clean and pat it dry. Don't be rubbing. Make fissures on your own self. So don't rub, pat dry, right? That's common sense. You remember smoking had a detrimental effect on Crohn's and wasn't going to help nobody else. So stop it, shit. And explain why. Explain this is going to be really ugly for you. You might need a nicotine patch or something to help this patient get through, but they cannot smoke. This is like horrible, for real though, okay? Oh, you know if I'm talking about basic care and comfort and generating solutions, part of the clinical judgment model. You know I'm about to talk about that diet because diet all day long is supposed to be nursing. So watch this. High calorie because your behind is malnourished, you might be losing weight. High protein because it promotes healing. Small frequent meals, right? That's common sense. With some snacks and all up and in between there. You got to be eating 5-6 times a day. Push fluids because you'll last dehydrated. Low fiber. You don't need no fiber. I catch corn in your shit, it's going to be a problem. So no corn, no seeds, no nothing like that. Okay? No, when we say low fiber, another way to say that, you might want to make sure you write this. Another way to say that is low residue. Another way to say that is bland food, you know, rice, baked chicken kind of thing. No dairy or low dairy, or cut out the dairy or whatever the hell, because that can make this worse. Decrease fat. You rolling with me? Cut out the caffeine, spicy foods, fried foods, acidic foods. Don't drink no damn pop. And you sure as hell ain't drinking no alcohol. Sound like your little ass about to be bored out of your mind, not having any fun at all. That's good. You need to chill for a minute. Okay, so no nothing. You're boring right now. Rice without the butter and the pepper. Rice and some, you know, baked chicken with a little broth on the rice. Get your ass some bread, not no whole wheat, not no whole grain. Get your ass some boring, plaster in the wall, white bread that nobody should be eating unless they got this. Okay. Now, so I'm just saying, you know, you got to know this. Any vegetable you call yourself eating can't have skin on it and must be cooked real soft. Yeah, almost digested in the damn boiler pot. Okay? Anyway, keep it moving, shit. Your patient is terrified. Remember, especially ulcerative colitis. Your patient is terrified about being incontinent of stool, and with ulcerative colitis, they had the bloody, mucousy stools. So that patient who's terrified of being incontinent of stool and somebody being in the bathroom, our crazy hospital still got 2 people in a room, which is fucking crazy, but it is what it is. So you need a bedside commode and a bedpan. Patients don't want to really use a bedpan, but you hook them up. You get that bedside commode in there, they'd be so happy. Extra toilet paper, right? I done seen the bedside commode with no toilet paper nowhere. Get the wipes that we use to clean our own patients. Give them a ton. Preferably if they're warm, it's really nice, but if they're not, that's okay. They're going to be very thankful, because toilet paper can be raw, and you know, toilet paper in the hospital is a piece of shit. It's like it tears up and it's crazy. So the wipes are better, okay? Now, we're going to say for almost everybody that's admitted to your hospital, you probably could be proactive and get them an ostomy nurse consult, because our ostomy nurse consult also does wounds, and if fistulas and fissures and excoriated bottoms and all that is involved, they can help with that as well. But again, look what I put as needed, right? PRN. But as God is my witness, a lot of these patients are going to have the need for this nurse, okay? Not everybody. That's why I said as needed. Then what are you teaching? Because this patient, it didn't cause the problem, but it certainly can aggravate it. This anxiety, this stress, this depression, certain life events. You know, I told you earlier I was divorced and married and divorced 17 times. And so, you know, you get used to it after a while. I don't think I feel any stress at all now. Baloney. And it wasn't 17, but that's just between you, me, and the walls. And keep sipping your tea, you'll be okay. But what I'm saying about these patients is they're very highly stressed for whatever reason. Maybe they got served divorce papers. Maybe they lost their job. Maybe they're facing an eviction. Life events happen to these people a lot, and it just makes all of this much worse. So what are we doing? Because you already made them stop smoking, so you done took their little crutch away. They can't even rely on this no more. So what are you doing? You're teaching how to decrease the stress. Yoga, biofeedback, Tai Chi is another way. Support groups are huge. It feels much better to be in a group of people who have gone through what you're going through, can tell you how to get through it better, what not to do, what to do, and just be there for you in a way that no one you know can, because no one understands what you're going through, right? And then sometimes these patients will need TPN. Now, I want you to remember, if they need TPN, that's called total parenteral nutrition. That means they have to have a central line. There is something called PPN. That's peripheral parenteral nutrition. So that's a peripheral IV. It is common to have one or the other with patients that are really, really sick. What I want you to know, no matter if it's a TPN or a PPN, peripheral or central line, It doesn't matter. Monitor the blood sugar, because these TPNs and PPNs have a lot of blood sugar, have sugar in them, so they can make your blood sugar go up. Monitor the white blood count, because the formulas in the TPN and PPN have a high sugar content. They attract bugs, right? So you know how it is. That's why I don't eat sugar, because infection can't survive without sugar. So you put this central line in with the TPN, and you already know a central line infection is called what? CLABSI, central line bloodstream infection, CLABSI. So we're monitoring the white blood count, and we're monitoring for infection, right? And plus you have a sugary line, so bugs love it. So you really have to watch that as well. The albumin was the original reason for why you have a TPN or PPN. The nurse is monitoring the albumin levels on patients with these lines. And the reason for that is albumin is a nutrition lab. And I got a nice trick for you. With albumin, I tell you to remember small, frequent meals with snacks. So if you do remember that, that means that their albumin level needs to be 3+, because what do? We eat 3 times a day. I don't, but maybe you do. 3 meals a day was standard back in the day, right? Well, albumin of 3 is still kind of low. So 3 meals plus snacks. So a 4 is wonderful. A 5 is delightful. Even a 3.8 looks better than probably what they came in with. Many of these patients will come in with albumin level of 2. Okay. Now, they're also going to be ordered supplements and elemental formulas. Just know that those are supplements that the nutritionist decides that they are going to need based on their lab report and their nutritional, their malnutrition level. So that's just there for you to know. And then pain management, just remember no NSAIDs. I don't care if the doctor writes for them. Depending on what's going on, you kind of got to question that order. So no NSAIDs. Very often, these patients need some serious medications when they're first admitted. Don't underestimate how severe the abdominal pain is. It's really, really bad. So love on them a little. Some people like warm compresses around the belly area. Offer them that. That might help. Whatever you can do to make it better. And then monitor for complications as part of you generating solutions, right? I mean, you're taking care of a patient that you're trying to think, what kind of nursing care am I providing? And so when you look at monitoring for complications, you're watching the temperature, make sure they're not becoming septic from like a peritonitis or something. You're listening to bowel sounds, making sure they're not getting a bowel obstruction. You're palpating the abdomen, making sure it's not rock hard and rigid, because that would be peritonitis and perforation, or GI bleed. You're monitoring the color of the stools, because black and tarry is melena and bright red is hematochezia. And so you're just monitoring everything. You're monitoring kidney function, blood pressure, everything. Yeah, I'm done. I told you it'd be a little shorter. Not much. 30-some minutes, but you better stay focused though, okay? So I will talk to you later. I got a couple more parts to do. Bye-bye.